Welcome to Session 2. In this presentation, we will discuss steps to solving a medical coding exam case study. But first, I want to introduce you to the team. First up, Mr. Sandeep. Mr. Sandeep coming to you live from Abu Dhabi. He is an AMCI co-lead instructor. Next up, Miss Eva coming to you live from the state of Florida. She's also a co-lead instructor and the intern coordinator. And finally, myself, Mrs. J. I'm the curriculum director at AMCI. Now, let's meet the AMCI interns. We have Miss Anubama, followed by Miss Carla, Miss Courtney, Miss Dolly, Miss Vivian, and Miss Melissa. Now that we're all acquainted, it's time to review the goals of the presentation. We only have one, that is the nervous system. We will dissect scenarios from the nervous system. Now let's talk about how to solve a multiple choice case study scenario the AMCI way for the board exam. This is how we do it. We teach you to highlight your key terms, and this key on the right tells you the colors that you should use and for what. A yellow highlighter should be used for diagnoses, all diagnoses, signs, and symptoms. The green will be for procedures. So if you have a green highlighter, the green will be used to highlight only procedures. And pink, these are inclusive or bundled items. All right? Once you've done your highlighting, you're going to have to document your inventory. That's your procedures, diagnoses, and select a primary code. Which diagnosis is primary, which procedure is primary. Then you're going to review all pertinent guidelines. And finally, the code that best matches your inventory list is often the correct code, or a code that is pertinent to a guideline. That will be your best code. All right. So here are some do nots. When you're highlighting, you can kind of get discombobulated. So we've compiled some things that you don't even have to highlight. Number 1, don't highlight things observed by the physician because you cannot code for them. Number 2, don't highlight closures. If a provider or surgeon is closing up a surgical site, there's no need to highlight it. However, if it involves a skin procedure or skin defect closure, you may definitely have to code that. So if it's closing a surgical site other than skin defects or wounds or lesions, you do not code it or highlight it. Also, you don't highlight bleed control, hemostasis, because that's pretty customary and it's bundled into the procedure code. You don't highlight drains, irrigation of the surgical site. Nope. And you don't highlight installation and removal of clamps and trocars because these are used to open up or maintain the surgical or operative site so the physician can view what they're doing, particularly if it's an open procedure. Also, you don't highlight dressings. And finally, you do not highlight surgical risks. Now that we've gotten that out of the way, I think you're ready to get started, and I'm going to hand it over to Mr. Sandeep. All right, Mr. Sandeep, take it away.
Next, we are moving into the nervous system chapter. And let me invite Miss Vivian to the stage to read this scenario for us. Miss Vivian, take it away.
All right. What are the CPT and ICD-10 CM codes? A. 61304 606.4XOA V89.2XXA, B. 61312 606.4X0A for V89.2XXA, C. 61314 606.4X0A V89.2XXA, or D. 61313 S06.4X0A V89.2XXA. Preoperative diagnosis, acute epidural hematoma. Postoperative diagnosis, as above, anesthetic agent, general endotracheal, operation, left craniotomy for evacuation of epidural hematoma, emergent. Indications. The patient presented with a history of a motor vehicle accident. He presented to the emergency department neurologically intact. An urgent CT scan revealed a large epidural hematoma, and the patient was taken emergently to the operating room for evacuation. Procedure, techniques, description of findings, condition of patient. The patient was brought to the operating room and after induction of adequate general anesthesia, was prepped and draped to the usual sterile fashion for a left frontotemporal parietal craniotomy. A curvilinear incision was made beginning just anterior to the left ear, curving posteriorly, then upward and anteriorly, to and at the hairline just off the midline. The resulting musculocutaneous flap was then reflected anteriorly. Multiple burr holes were then placed and connected using the high-speed drill to create a large free bone flap. This was removed from the immediate operative fields. Directly beneath the bone flap was a large, well-formed clot which delivered itself from the epidural space. A bleeding point was found in the region of the middle meningeal artery. This was carefully and thoroughly coagulated using bipolar cauterization. A small opening was then made in the dura to ensure that there was not an underlying blood clot. There was not. This opening was primarily closed using 4-0-Neurolon. Additional meticulous hemostasis was then obtained. The bone flap was then replaced and held in place using multiple KLS fixation devices. Skin was then reapproximated using 2-0 Vicryl for the subcutaneous tissues and 5-0 monocryl for the skin. The patient was then awakened from anesthesia, at which time his vital signs were stable, and he was neurologically improved from preoperatively. Estimated blood loss was 100 cc, specimens none, lab orders none, diagnostic procedures ordered none, complications none. Okay, coders, your time begins now.
Time's up, coders. 2.5 minutes is done, and let's solve the scenario. We have a little bit more time, so I will quickly go through this scenario. Keywords: preoperative diagnosis, postoperative diagnosis, same as the preoperative diagnosis, which is acute epidural hematoma. The procedure performed is a left craniotomy for evacuation of epidural hematoma. Patient indication: the patient had a history of motor vehicle accident. General anesthesia was given, and a frontotemporal parietal craniotomy was performed. This is a one-part surgery which is performed: frontotemporal parietal craniotomy. A curvilinear incision was made to the anterior to the left ear. Musculocutaneous flap was reflected anteriorly. Multiple burr holes were made to create a large bone flap, and directly beneath the bone flap, clot which was delivered itself to the epidural space. So the blood clot is in the epidural space, coagulated using the bipolar cauterizations. Opening was then removed. Opening was then made in the dura to ensure that there was no underlying blood clot, and this opening was closed with a 4-0 neurolon. The bone flap was then replaced and held in the place. So the correct answer to this question is going to be option B. Okay, I was just looking into the chats. Let's just solve this one. The procedure inventory, as I said, it's a left frontotemporal parietal craniotomy for the evacuation of epidural hematoma. The diagnosis inventory, we are having acute epidural hematoma. Let's look into option A, which is 61304, which is craniectomy or craniotomy exploratory supratentorial. Now this one, as I highlighted, is coding for exploratory procedures, and we are having procedure performed is for evacuation of an epidural hematoma. That's why option A is wrong one. Incorrect answer, option A. Now let's have a look into the remaining codes: 61321, 61323, yes, there are 313 and 61314. And let's do some churning. 61312 is coding for craniectomy or craniotomy for evacuation of hematoma. So that portion is correct. It is used for evacuation of hematoma. The next portion is to identify where the hematoma is. 61312 is coding for evacuation of the hematoma in the supratentorial region. It can be extradural or subdural. 61313 is coding for evacuation of the hematoma in the supratentorial region, intracerebral. And 61314 is coding for craniectomy or craniotomy for evacuation of hematoma as well in the infratentorial region, extradural or subdural. So before moving on to solving the scenario, let me show what an epidural hematoma hemorrhage is. Epi means above, dural means outer protective layer, that is dura mater, and hemorrhage means bleeding. So epidural hemorrhage means bleeding above the dura mater. So you can see from this image. So again, let me grab the laser. This is a dura portion, the outermost protective layer, and the hemorrhage or the blood clot is happening above the dura. That is epidural hematoma over here. So just below the skull over here. Okay, let me go ahead, and the key thing for solving this scenario is to locate where the hematoma is. All the options we are having except the option A is coding for evacuation of the hematoma, and it is all differentiated by where the hematoma is located. So you can see the terms like supratentorial, intratentorial all over the place, and let me explain what a supratentorial and infratentorial is. So tentorium is actually a line that the border which lies between the occipital lobes and the cerebellum. You can see this is the tentorium. One second, let me grab the laser highlight. This is the tentorium portion, and above is what we call the supratentorial portion, which is the cerebrum, and below is the infratentorial region, that is the cerebellum. Is that clear, coders? Is that clear for you so far? Yes. And with that in mind, let's go ahead and do some coding. Option C is wrong because we are coding here. Where do you think the hematoma is located? It is located in the epidural region. It is an epidural region. And I said it is located in the frontotemporal, the frontotemporal parietal craniotomy is a procedure which is performed. And the parietal location is actually over here in this particular portion. It's over here. So the hematoma is located in the supratentorial region, and it is not located in the infratentorial region. So option C is incorrect because it is coding for a craniectomy or craniotomy, and the location is infratentorial. For 61314, if a hematoma is located in the infratentorial region over here, that's when we use this code. Now let's look into the next one, 61313, which is coding for supratentorial intracerebral. Was this an intracerebral hematoma? That's why I explained what an epidural hemorrhage is. Epidural and extradural, both are the same. Yes, extradural. That was not an intracerebral cerebral hematoma. It was an epidural somewhere over here in the parietal region. So that's why option C is also incorrect. And the correct code for our scenario will be 61312, which will be craniectomy or craniotomy for evacuation of the hematoma, supratentorial, extradural, or subdural. So this one explains where our hematoma is and where the craniectomy procedure was performed. How do you
Mr. Sandeep, we're not hearing you.
I'm sorry, I got myself double muted. Sorry. Yes, a little bit tough because once you know that location, it would have helped you in solving this one. So let's quickly move to the next scenario. If you have any questions on this scenario, please put in the chat. I'll be working on that. So thank you, Miss Vivian, reading out the scenario for us. Let's welcome Miss Anu to read the next scenario. Miss Anu, take it
Yeah,
away.
okay. What are the CPT and ICD-10 CM codes? A 64493 modifier 50, 64494 modifier 50, and M 51.36, B 64483 modifier 50, 64484, 64484, and M 51.36. Answer C 64493 modifier 50, 64494, 64495 M51.36, and the D 64493 modifier 50, 64494, 64494 M51.36. Pre-operative diagnosis: low back pain, degenerative lumbar disc. Post-operative diagnosis: low back pain, degenerative lumbar disc. Procedure performed: bilateral paravertebral vertebral facet joint infection of steroid at the L3, L4 and L4 to L5 with fluoroscopic guidance. Description of procedure: the patient was transferred to the operative suite and placed in the prone position with a pillow under the abdomen. A smooth for sedation was given with the midazolam and fentanyl. The patient's back was prepped with betadine in a sterile fashion, and we used lidocaine 1% plain as a local anesthetic at the injection site. With the use of fluoroscopic assistant, first to the right and then to the left 20 degrees, the Scotty dog view was identified, and we were able to place the spinal 22 gauge needle first to the right L3 to L4, and then to the right L4 to L5, then to the left L3 to L4, and then to the left L4 to L5. We used a lateral X-ray to assess the proper placement of the needle. We proceeded to inject a mixture of 4 ml of 0.25% maracanine plain plus 80 mg of methylprednisolone divided between the four joints. The needles were removed. The patient's back was cleaned and the band-aid was applied. The patient was transferred to the recovery area with no apparent procedural complication. Coders, the time starts now.
Two and a half minutes, coders. If you haven't finished, please go ahead and take the screenshot of this scenario and work on it. And let's move on. Let's solve the scenario. I did wish to complete one more scenario, but I'm not sure we'll be able to complete that on time. So let's do this right now. Post-operative diagnosis, we are having low back pain, degenerative lumbar disc, and the procedure performed is a bilateral paravertebral facet joint injection of steroid at the level L3 and L4 and L4 and L5 with the fluoroscopic guidance. So I would like to bring your attention over here we're having two levels only, L3, L4, and L4 and L5. So we are coding for two level injections. Okay, let's move on. The patient was placed in prone position. IV sedation was given with the use of fluoroscopic guidance, first to the right, then to the left. The spinal 22 got needle, first to the right L3 and L4, then to the right L4 and L5, and then to the left L3 and L4, then to the left L4 and L5 was made. The X-ray was used to assess the proper placement of the needle. A marcrine plane plus 80 mg of methylprednisolone was divided into 4 joints. And the correct answer for this scenario is going to be option D. Yes, we are only coding here for two levels. We are having L3 and L4 and L4 and L5. So I hope you all are clear on the levels which we are coding here, because that is also important in solving this scenario. We are coding for two levels. Yes, I'm glad to hear that. Okay, now the procedure inventory, we are having fluoroscopic guided bilateral facet joint injection of a steroid at the L3 and L4 and L4 and L5. That's two levels. And the diagnosis inventory, we are having degenerative disc disease and low back pain. Since the low back pain is a symptom of a degenerative lumbar disc, we won't be coding them separately. And let me show the diagrammatic image of what a facet joint looks like. So each level in a human body in the spinal region has actually two facet joints. One can be on the right side and one can be on the left side. So in our procedure, the injection is given to the, let me grab the highlighter. Okay, injection is given to the facet joint over here, and the level which we use is L3 and L4. And another injection is also given, injection of a steroid is also given between the level L4 and L5 in this particular facet joint, and you can see it is performed in bilateral facet joints. So if this is one is the right facet joint, there is a left facet joint as well in the other side. And this is another diagrammatic representation. So you can see here, if this is the right one, there will be another present the other side on the left side as well. So the injection is given bilateral facet joints in the both sides. And you can also see the nerves, spinal nerves, which is going through this facet joint. So the facet joints are actually the connection between the bones of the spine, and these nerve roots pass through these joints, and it will go on to the spinal cord, to the go on from the spinal cord to the arms, legs, and other parts of the body. So I think the anatomy portion is clear, and we are also having our FTS over here. Remove the laser point. Okay, let's do coding, coders. These are our code options. Let's look into option B, 64483 with the 50 modified, 64484. The 64483 is coding for injection, anesthetic. Just hold on a moment, coders. I will be just back. 1 second. I'm back. Something went in the backside. Okay, so let's come back to coding. The option B, 64483, which is coding for injection of anesthetic and or steroid in the location of a transforaminal epidural with image guidance, fluoroscopy or CT, lumbar or sacral, single level. So we can eliminate this option right away because of the location. We are coding here for facet joint injection rather than an epidural transforaminal injection. You guys see we are coding for bilateral facet joint injection and not for a epidural transforaminal injection. That's why option B is incorrect. Let's see option C, 64493. Let's see what it is coding for. 64493 is coding for injection of a diagnostic or a therapeutic agent, paravertebral facet joint. That's good. With image guidance, fluoroscopy or CT, lumbar or sacral, single level. Okay, now let's look in the next code. 64494, which is coding for a second level, additional second level. And we have 64495 as well in option C, which is coding for a third and any additional level. So did we had 3 levels or 3+ levels coders? That's why I said how many levels were present in the first place. No, yeah, yes. We didn't had any third level. We just had 2 levels. So option C is incorrect. Let's look into option A and option D. Now option A is coding for 64493, which is correct, which is coding for injection of steroid into the facet joints, paravertebral facet joint at a single level with a 50 modifier. That's good so far. And 64494 is coding for a second level with a 50 modifier. Yes, we did a paravertebral facet joint injection at bilateral level. That means in the first level also we went for a bilateral injection. In the second level also we went for a bilateral injection. And I'm sure that's why most of us picked the option A as the answer, choose the option A answer as the answer. But option A is incorrect. Why? Because of these specific guidelines. If we go into the paravertebral spinal nerves and the branch page in the CPD book, you can see these guidelines. Image guidance, that is the CT or fluoroscopy, and any injection of contrast are inclusive component of the code series of 64490 to 64495. So you don't code them separately. And then you can see a guidelines over here, which is very important for solving our scenario for bilateral paravertebral facet joint facet injection procedure. Report 64490, 64493, which is the pattern code. So 64493 is our parent code with a modifier 50. Yes, bilateral injection was given. So we given 50 modifier for the parent code. And then later on you can see, read the add-on code 64491, 644, report the add-on code 64491, 64492, 64494, 64495 twice when performed bilaterally, and do not report modifier 50 in conjunction with 64491, 64492, 64494, or 64495. How about that, coders? Did you got the trick? You got where you all went wrong? So never go straight ahead and solve the scenarios like that. If you see a 50 modifier and assume that is a bilateral procedure, always you can also go ahead and always cross check with the guidelines which we have, the specific chapter specific guidelines, especially going forward into the medicine section. You will see a lot of those such guidelines. So before next week we go into the medicine section, I think. So please go and have it chun all these guidelines. That's why chunning will help you. You won't have much time to go and check these guidelines, but if you have chunned these things in your CPT book, you will know there is specific guidelines over here, so you can have a quick reference into those like guidelines before those chapters, and this can really be a turning point and help you differentiate between the correct answer and wrong answer. So on a general way, this one 50 modifier can be also correct, but here, since we have a specific guidelines not to use a 50 modifier for the add-on codes, option A is incorrect. See, and the correct one is option D, 64493, and a 50 modifier. We appended 50 modifier for the primary procedure parent code. That's as per the guidelines. And for the secondary second level, we used quantity 2, that is 64494, 64494 two times. And the diagnosis will be M51.3. I hope that helped. Yes, please go ahead and churn before you come for the next week. I think it's already time, and we had two more scenarios for today. We will cover that in the next and the fourth session. That will be our final live sessions. Okay, coders, thank you. Thanks a lot for being here with us. I hope it helped you. You learned something new today. Thank you. Thank you all, and thank you for Miss Anu for reading the final scenario for me as well. Thank you, everyone. Thank you, team. Thank you, coach. We'll see you next week.
Thank you, Mr. Sandeep, for those AMCI amazing and awesome explanations. Miss Eva, for being the orchestrator and conductor of the best interns on the planet. Yes, I said it. Miss Melissa, Anubama, Courtney, Carla, let's get it, let's code, Dolly, and Miss Vivian. And let's not forget our interns in the chat, led by Miss Biji. And you, the students, you all are simply the best, and we appreciate you. And we will see you next time for more great scenarios. You don't want to miss it. And thank you for participating in the AMCI Medical Coding course. Until next time.